Education Sciences and Disorders here at SLU.
Louder. Darcy. All right, is ready to go?
Yeah.
Okay. You will.
Hi, we're Team 22. My name is Madeline Schultz. I'm an occupational therapy student.
My name is Dora. I'm a social work student in WashU.
My name is Max. I'm a pharmacy student at St. Louis College of Pharmacy.
My name is Ashley Banks and I'm a second year graduate nursing student.
My name is Megan McDarby. I'm a second year psychology student.
Hi, I'm Beth Cotney and I'm an occupational therapy student.
So we wanted to divide up Susan's chart by the patient Susan and the person Susan. So the patient Susan is everything that health professionals focus on. So her diagnoses, where she's living, her age, and we really want to point out that she is entering hospice care. So from here on out, we just want to make her comfortable. We don't want to go through everything. We just wanted to give you a quick overview of her very complicated case. So as the person Susan, I want to point out that her mother did die of breast cancer, and it was very painful. So she has a very different lived experience seeing her mother go through the same thing. We also want to point out that her closest family is in Chicago, so she doesn't have a very close family and social interaction in St. Louis. As a team, we wanted to make a SWOT analysis. We wanted to identify her strengths, weaknesses, opportunities, and threats. And so then as professionals, we could really hone in on the big picture, things that we wanted to focus on as a team. I want to point out that she does enjoy community involvement. It just has not been available to her as she progresses in all of her diagnoses.
So here's our interdisciplinary team. Basically, we covered these three circles. The first one is social services, and the second one is therapist, and the third one is like medical professional. And together, we're gonna work out a plan.
Okay, so why interprofessional? Well, our number one goal here is to provide patient-centered care, and we want to make sure that we're providing effective care and safe care. So Ms. Watson is a unique patient, and she presents with unique issues. So we want to address those in the best way that we can. And interprofessional collaboration is pivotal in addressing her complex needs: medical, psychological, social, functional, as well as spiritual. And that's how we built our team. And by working as a team, we are able to better provide holistic care to Ms. Watson. So here the top map is going to be a map of care coordination. And what it is, it's a visual to see our patient care activities. And they all overlap and they all are fluid. So as each of us are members of the interdisciplinary team, we each will play a part in each component. So assessment, for example, as her nurse, I will make sure I'm constantly assessing her pain. Is her pain controlled? Is it the pain is what she says it is? Is it where she wants it to be? The physician would also be assessing, make sure is her pain controlled? What is her disease? How is her disease progressing? Same with advocacy. Each component here is overlapped by all of our disciplines. Down here is a more specific components of the patient care, and so these things are also going to be addressed, so like her nutrition, her personal care and hygiene, her mobility and activity, and so on and so forth, and our patient here is always at the center.
So currently, our team has three goals. Starting from the bottom, we need to do some patient education, and by education, we do not mean that we are educating her. We're just providing knowledge and make sure she's not only listening, but also understanding and hearing what we're saying. Here we want to use the teach back method to make sure that she's understanding and can teach us back whatever we told her. And the second one on the left is establish and maintain social relationships. From the case, we realized that Susan really does not have much social supports, and that's something the social services part will be working on. And up there on the right is chronic illnesses maintenance and management. So at this stage, our focus regarding her chronic illness conditions, we'll be focusing more on maintenance and management rather than treatment.
These next couple slides are going to go over the roles and responsibilities of each team member and how they apply to Susan's care plan. So we have the management of her comorbidities. So she has COPD, the physician, respiratory therapy, nursing, occupational therapy, and pharmacy would like to give her an oxygen tank, work with her to get that situated with her wheelchair or her scooter, and then adjust her medications. She has obstructive sleep apnea, respiratory, and physician would like to help with that. Physician, pharmacist, and nursing would like to help with her hypertension to maintain this and properly treat it. The physician and pharmacist would also like to work with her chronic kidney disease because it is shown to be worsening and may need adjustments for her medications.
And so her diabetes management, we kind of wanted to make its own thing just because the diabetes is going to play a really big role in how her disease conditions are progressing. And so we want to really make sure that we build our support team. And we have that. We've already mentioned it. But we also want to include a diabetes educator. Number 2, get the patient involved in the care. We want to make sure that Ms. Watson understands the difference between her hypo and hyperglycemic events. We want to make sure that she knows what foods are going to spike her glucose levels. And so she likes to online shop, so we want to use that as an innovative way to get her to learn and to manage her diabetes better. So we'll even recommend that she does online programming for managing her diabetes. We also want to make sure she's focused on losing/maintaining her weight, becoming more active, again, focusing on the food and lowering her stress levels.
Whether she's at home or in a facility, we want to really increase her environment safety. We're going to do that by PT and OT evaluating and modifying any risks. And OT and pharmacy and nursing are really going to work on her medication management. In her own environment, it's very, very hard to manage your medicine and extensive medicines in this case. So we really want to integrate a electronic pill bottle or something of the sort. Nursing and OT really want to work on transfer safety as well as hygiene safety. We want to get the family members involved again. Perhaps if she stays in her home to go through her personal items and either organize or discard. And the psychologist, we really want to work on educating and also starting a real discussion about her hoarding difficulties.
In the case, it talks about Miss Watson having pain in her hip and back. And I think OT, PT, and nursing can work on just fall risk supervisor because obviously falling can increase her pain. And OT and PT can also work on the strengthening to make sure her muscles are working well so she can try to maintain herself so she won't have any more pain. And then pharmacy and nursing would like to work with her medication to make sure she has the proper amount. It's around the clock and it's not gonna put her in just a sedative state and make sure it's just more regulated. And then also it talks about how Miss Watson has a lot of health conditions with obesity and diabetes, and the dietitian and the OT like to work together to help look at her meal time and see how she's preparing meals and make sure she's not having malnutrition and making sure she knows what to eat. And she said she only makes simple meals so they can work together to help make her meals a little bit more healthy and make sure she gets out all her nutritional needs. And nursing would like to further just evaluate her food and make sure her intake and outtake is monitored and just give her more education.
One of the biggest issues for Ms. Watson is her social isolation and the potential loneliness that will ensue. We haven't discussed this thoroughly yet. We will towards the end, but it's still sort of up in the air what's going to happen in terms of Ms. Watson's living situation. She doesn't really want to go to a nursing home, but she's at home, which is pretty unsafe right now. And even though we have measures to promote her staying at home, like we just talked about with physical therapy and occupational therapy and the nutritionist, we still want to have a discussion with her about what could be the benefits of moving into a skilled nursing facility, one of which would be to increase social interaction. So the psychologist and social worker are going to lay this out for her and sort of explain, you're staying in your home, these might be the social disadvantages of being at home versus being in a structured environment like a nursing home where she would have access to more social interaction activities, things like that. The audiologist is going to work with Ms. Watson because she is experiencing some hearing difficulties, which could be impairing her social functioning. So that's going to be a conversation between them, and hopefully that will improve her social interactions as well. We're going to get the chaplain involved because Ms. Watson was a religious person and might still be interested in engaging in religious things. So if she stays at home, we might be able to get some members of the church community to come over and volunteer to sit with her, or get her more involved in services. And then we also want to try to solicit support from Ms. Watson's family members. It's hard to say how involved they want to be since they live in Chicago, but that could be a way to promote social interaction as well. The second key issue that falls within the social domain is Ms. Watson's lack of preparation for end of life. She is starting hospice, but she really has no idea about what hospice entails, and she also hasn't undergone any advanced care planning. So the psychologist and social worker will start with a cognitive assessment to see whether or not she has the capacity to make her own healthcare decisions. Regardless of whether or not she does, she still needs to work on appointing a healthcare proxy who can help her make those decisions when she gets to a point where she can't by herself. We'll be planning for future care. We'll have the nurse, physician, and pharmacist all weigh in terms of providing medical advice, maybe talking to her about those more difficult end-of-life decisions like feeding tubes or having a breathing machine, things like that. And then we'll also have a consult from the palliative care team. Given that Ms. Watson has so many chronic illnesses that she's managing right now, it seems necessary and useful to get their input about how we might work on pain and symptom management. In order to accomplish Ms. Watson's end-of-life care planning, we'll be using the Prepare for Your Care module, which is an online tool that was developed by some psychologists out in California. Since, like we said, she does a lot of online shopping, we know that she's pretty equipped to do things online, and this is an interactive tool that's pretty basic. It allows you to save your progress, and then at the end, it spits out an advanced care plan that she'd be able to hand to her providers, us, for future care.
So how will we ensure effective teamwork and communication? Well, we're going to develop a communication strategy, and what that means is first we want to identify possible barriers, like time could be a barrier. How are we going to most effectively and efficiently get those messages across? Those could be by phone calls, emails, text messages. We want to create a communication process. We want to make sure chain of command, who needs to be contacted and when. When should we contact the physician? When is nursing? Can we stop at nursing with PT and OT? We want to multiply the message, make sure we're documenting the things that we're doing, explaining why, make sure we create an environment where we all can openly talk about why we make the decisions that we made for Ms. Watson, and always know that there's always room for improvement. And we want to create feedback process, and that's to evaluate our outcomes and make sure that we're making them better each time.
After all this, we see three possible outcomes of the situation. We think possibly a skilled nursing facility in Chicago. A benefit of that is it's closer to her family, but whether she doesn't really want to go to a skilled nursing facility, and that's for both option 1 and 2. Because it's one in St. Louis, she could be closer to her friend Susan. Sarah. And then her last option could be staying at home. It's not preferred by the healthcare teams because their home doesn't seem as safe. But if she really wants to do that, they could all work together with her to try to make her home a safer place.
We also developed a list of community resources that might be available to help Susan, especially if she decides to stay at home. So the first would be volunteer transportation services. There are a couple of different options in St. Louis as well as Chicago. That would be if she's in skilled nursing, but if she's at home in St. Louis, that might help her get to church if that's something that she decides she's interested in, or more social activities that are outside the home. We've also identified resources at BJC Hospice in St. Louis, including the transitions team, which helps patients who aren't fully ready to accept hospice or don't fully understand what hospice entails. They come in and provide some psychoeducation and counseling to the patients. And then also the incorporation of faith-based organizations, like I mentioned earlier, having volunteers from the faith community come and visit with Ms. Watson to promote social interaction and just connectedness with the community. So in order to evaluate outcomes, we want to focus both on evaluating outcomes for us and then evaluating outcomes for the patient. And we realize, and I think we realized from this experience, that sometimes it can be difficult to keep in touch with other members of the team. But we've identified some ways to track our progress. So we'll be sending out bi-weekly surveys to each other to rate the frequency of the contact as well as the method of the contact. So was it via email, was it via phone? We'll also be tracking our core goals over time. So how well have we accomplished these goals that we set out to achieve with Ms. Watson? In terms of patient care, we'll be monitoring her psychological status by weekly geriatric depression scale and geriatric anxiety scale scores. We'll also monitor her progress on completion of advanced care planning, status changes with regard to some of her chronic conditions, and keeping up with the family and how much we've involved them.
So the quality improvements and patient safety. So we want to psychoeducate, make sure that the patient understands the concepts and they're able to identify the obstacles that are in front of their well-being. We want to maximize the patient's quality of life, make sure that they're comfortable with the treatment decisions, and deliver patient-centered interdisciplinary care, and make sure that the team members are looped together, and make sure that the team members demonstrate consistent communication with each other.
We learned a lot of lessons through this process. As Megan said before, communication is a really big thing. We are really busy students and soon we'll be really busy professionals. So keeping in communication is a big barrier that we'll have to overcome. We found success through an email that we just kept replying back to, so we didn't leave out anybody, which is big on having a very large care team, just so everyone knows that they're on the same page, whether it has nothing to do with OT, just so the OT knows what's going on with Ms. Watson. Also, we learned that, I learned that it's very important to get every part of the patient, especially going back to the person versus the patient. Sometimes the happiest patients are the ones that have a care team that take a step back from the information in their chart and look towards who this person is. And we really, as a team, wanted to focus on not just what is on her chart, but also how she feels as a person with her cats and her family. And she is a unique person, and I think this progress was very beneficial, and we all learned so much. Thank you so much.
Thank you. Thank you. Great.
Sure.
It'll be the same question.
It's a good one.
So you have a lot of components. There's definitely a lot to consider. What was the most challenging for you as a group to come to maybe a point of agreement or a plan that you were comfortable with? Like, what aspect of Susan's care did you find the most challenging as a team?
I think one of the biggest hurdles that we had to overcome from the start was figuring out where she was going to go, because there was this huge conflict between what she wanted and delivering person-centered care, which would be staying at home, but then dealing with these issues of hoarding and living in an unsafe environment, not being very mobile, being socially isolated. So we were like, do we want to send her to a nursing home? Because that's not really patient-centered care, but is that the safest option for the patient? And we did have a pretty lengthy discussion about that. So I would say that, and then we really all weighed in on our own professional opinions about why we thought one might be better than the other. And then ended up leaving it super ambiguous. We didn't have to make a decision.
Just like real life.
Yes. Yeah. Does anyone else have any other?
The only thing I have to add is not knowing Miss Watson's income or her insurance was a really big, not issue, but kind of an issue in our discussion because every time we kind of got to a decision, we went back and we were like, wait, how much is this going to cost? Is it covered by most insurances? So that was a really big issue for both home care and a skilled nursing facility.
It always is a point of contention, yeah.
For sure.
For skilled nursing units, as opposed to the nursing home, do you know about the criteria when they take a hospice patient? Different levels that might be in a nursing home, skilled floor unit versus the
I mean,
residential.
skilled would be more about rehab.
Right. You had mentioned that was one of your options.
Yeah, but as far as I know, I don't know. I don't know for sure, but I feel like I have volunteered at skilled nursing facilities where hospice was making visits. So maybe it differs by state, but I know in New York State, I worked at a skilled nursing facility and there was a patient on hospice, so I'm not sure.
We just had a class on this in our OT program.
How
So,
convenient.
so we decided to stray away from acute care because, at least in an OT's definition, that's the 3 hours of PT, OT, and speech every single day, and we were like, there's no way. So we stayed away from that decision.
Skilled care, right, yeah.
And
Skilled nursing,
Oh, acute care.
the way they taught us is
Yeah,
to
for
acute
rehab,
care.
right.
Yes, okay, yes. And then skilled, we wanted her to have the some OTPT and respiratory therapy, so we decided to stick with a skilled nursing because in a lot of nursing homes, the OT comes how often? Not very often. So we wanted to give her that option to have the best care and to maybe be able to stay independent even if she did go to a skilled nursing facility.
So I'm curious, is that how you as a group landed with skilled nursing, or even though you left it up as 3 options, I'm curious where you fell on that?
We were kind of leaning towards that, but then the cats really got me.
That's my question.
Yes.
Where are the cats gonna go?
Yeah.
We were looking a little too far into this, but we were looking at facilities that have cats because there are.
Would they be her cats though?
We were also thinking that Sarah could take the cats or her family
Wishing,
members.
yeah.
It was up in the air, but the cats were a really big discussion and part of where she was going. So.
That was like the sticking point on decision. Any other questions?
That was her priority.
Just one
Yeah.
question on the nutrition. One of the things listed on your speech was some swallowing issues. When you talked about nutrition, you didn't mention the role of those swallowing difficulties in maintaining nutrition and medication, because it said about pills.
I was just looking at I was reading the Europeans their model of nutrition for the dietetics, and they were just talking about I thought it was more it seemed like she was had a big risk for malnutrition. I was focusing on the fact that she could only prepare really simple meals or a microwave meal, and due to all her health conditions diabetes, hypertension, she might not be getting the food that she should be eating. Because I also was reading how older patients are at risk for malnutrition and